Today, we'll be discussing nutrition assessment and patient care. This presentation will help you to discuss the basic nutrition status assessment that's performed by nurses. It will help you explain how the nutrition status of your patients can be compromised by illness and what the impact of nutrition status is on recovery. You should be able to describe the role of the registered dietitian and outline the process in which data is collected and a comprehensive nutrition assessment is conducted. You'll be able to compare and contrast the nutrition care process and the nursing process. And lastly, it will help you to summarize the types of potential interactions that can occur between food or nutrients and drugs. So in the first half of this presentation, we're going to talk about nutrition as it relates to our health and our wellness. And then we're going to talk about how nursing professionals interact with registered dietitians and other interdisciplinary hospital and healthcare workers to think about how nutrition pertains to the physiologic stresses of disease state. And QSIN, the Quality and Safety Education Nursing Competencies, are related to our patient care and their nutritional status. So if you remember, the competencies are patient-centered care, teamwork, collaboration, quality improvement, safety, and informatics. So first, let's think of the role of genetics on disease onset. And we know that genes affect nutrient metabolism, and we know that nutrients affect the way that genes express themselves. And it really does affirm the old saying, we are what we eat. And in fact, studies have shown that even in a woman's prenatal diet, it can affect the long-term health of their children. And this is referred to as the fetal origins of adult disease. So if that's something that you're interested in researching, fetal origins of adult disease. Additionally, placental insufficiency, maternal malnutrition, and even IUGR, which stands for intrauterine growth restriction, can impair an infant's growth. Eventually, this can lead to long-term hypertension, cardiovascular disease, and type 2 diabetes in adults. It's not only important to eat really well during our pregnancy, but we have to realize that the lifelong adequacy of our diet affects the onset and the severity of both acute and chronic diseases. And this accumulation of errors in the genome and damage to biomolecules can cause functional tissue damage, if not just damage, at least changes. It can also promote aging. So there's more research out there in the field of nutritional genomics, and it is quite cutting edge as we're starting to learn about bionutrients and how they relate to the genes in health and wellness. Eventually, I would suspect that a full DNA analysis could become part of a routine assessment. Let's think about the nutrition team itself. Now, first of all, our physicians are generally responsible for writing our admission orders, including the diet. And it's in addition to the physician staff, we have our physician's assistants, nurse practitioners, and other advanced clinicians that are putting together the diet plan. But nurses at the bedside are often the first health professional that is coming into contact with our patients. And so you are gathering this information during the initial assessments. It puts you in a really good spot or a good position to identify if patients need additional services, alternate services, or at least matching up what has been ordered to see if it really is applicable to the patient, because you will have more information oftentimes. You are often performing that basic nutrition screening and providing nutrition education. What makes up nutrition screening? In a basic nutrition screen, we have to ask the questions about changes in appetite, changes in weight loss, especially unintentional changes. We're talking about age, past medical history, family medical history, psychosocial history. We're talking about hydration status and illness severity. And something that's not on here, but I think is really important, is discussing the social determinants of health and trying to figure out if there is a deficit in nutrition, why and how come, right? So ask those more pressing questions to find out the real answers of why a patient might not be um, following the diet plan. The registered dietitian or nutritionist is another qualified professional that could conduct the nutrition care process and plan. And our registered dietitians, sometimes we just call them RDs, they're valuable. They're very valuable in working with our nursing team and working with the healthcare providers. And in the NCP, or the nutrition care process, it really is the detailed nutrition assessment, then establishing a diagnosis related to their nutrition, providing nutrition therapies, monitoring the therapies, and evaluating the outcomes. And nutrition therapy is often needed to treat an illness or an injury or a related condition. Dietetic technicians, and sometimes they're referred to as registered dietetic technicians or DTRs, they can also take a diet history, collect information regarding the nutrition screening and assessment, and they work directly with the patients that are having issues with their day-to-day meals. And a DTR may provide the basic nutrition education, but we shouldn't ask them to really counsel our patients about complex disease modifications. Let's define what medical nutrition therapy is, or MNT. Now, this is a legal term, and it applies to patients with pre-renal failure and patients with diabetes that need nutrition treatments under Medicare, so under our um, national insurance coverage. And so, to avoid any confusion, when this textbook refers to nutrition therapy, we're talking about the provision of food and nutrients, nutrition education, nutrition counseling, and coordination of care. We're not talking about the medical nutrition therapy as a legal term. So please differentiate between the two. There is an important relationship between our dietary intake and healthy populations, and the capacity for recovery from an illness or a disease process really depends on your nutrition status, whether you have a good nutrition status or a poor nutrition status. What happens when you have a poor nutrition status or a patient gets diagnosed with poor nutrition status? It really could delay their recovery. It could also decrease their overall quality of life. And it's important then to determine what their current nutrition status is as they're undergoing their medical treatment, and how are we going to help them return to wellness? And wellness is the goal. We have to be aware of undernutrition as well and chronic micronutrient deficiencies. This is sometimes referred to as the hidden hunger. Oftentimes, older adults, I'm referring to those that are over 65 years old, are more at risk for nutrition-related chronic diseases like heart disease or diabetes. But they're also more at risk for infections like pneumonia, influenza, and it requires strategies, policies, and interventions to really address this hidden hunger in which they may be participating in. And when we admit them to their hospitals or skilled nursing facilities, many of our older patients are already at nutritional risk. And because of this, the process of wound healing becomes delayed. They have longer lengths of stays overall, and it can really promote an overall decline in health. Additionally, when we have even more frail elderly patients and sick or chronically ill patients, they may experience a loss of appetite, depression, alterations of taste and smell perception, which then can secondarily cause a increase in their nutritional risk. So during a hospital setting or a patient during their hospital stay, we really have an opportunity to evaluate the eating habits and see if there's any opportunity for change, anything that we could address. And with the patients, they're away from their own kitchen and they're not preparing their own meals unless they're bringing them in, of course. But really, the hospital is responsible now for serving their meals mostly on a schedule, and it may not coincide with what the person typically eats or their personal preferences. And depending on the medical diagnosis, the food may be modified. And so think about some diagnoses that would warrant a modification in food. Now, obviously, with hypertension, there would be a low sodium diet. But what if someone's having difficulty swallowing or difficulty chewing? We might have modifications in textures and consistencies. A patient that has a high expenditure of energy may need additional nutrients. So while a patient's in the hospital, different staff are routinely entering the room. You've seen it. They're asking questions. They're trying to understand overall what's going on with the patient. Part of your nursing assessment is asking them what they ate, how much did they eat, and not only asking them about their inputs, but also their outputs. What are their elimination habits? Something to think about too is that our patients, many times, they're on bed rest or they're not able to move independently. And this could be something that is ordered by the healthcare providers, or it could be a limitation in their overall health. And because they lack the ability to ambulate, this could increase their risk of impaired skin integrity. They will have a decrease in muscle tone. It could affect bone calcium, plasma volume, and gastric secretions, depending on what the overall disease process is. Some other things to think about is that glucose intolerance may occur because there's no activity. And it really, because of this bed rest, it could accelerate previous disease processes. Maybe they already had a glucose intolerance and now it is worsened. And it's especially detrimental in our older population. And we have evidence that suggests that low intensity exercise and properly prepared meals may partially and temporarily protect the skeletal muscle that could be reduced during a hospital stay. And the types of foods that are being promoted within this study, English et al. And Galvin et al., are suggesting that leucine-rich foods are what we should be providing for these older patients. And these include whey protein, milk, beef, chicken, yogurt, peanuts, and even soy products. Additionally, because of the immobility, we may see shifts in body fluids and electrolytes. So again, this importance of monitoring and measuring the inputs as well as the outputs and getting labs often and watching to see if there are any visible signs of fluid shift that you can detect with your patient. Let's think about this terminology for a second. Now, additionally, not only are we thinking about preventing malnutrition by paying attention to inadequate diet orders, we are also looking to see if the patient is really eating. Um, if they're on a liquid diet for more than 24 hours, or if they're on some type of intravenous feeding that only contains glucose or saline, perhaps there are other nutrients that are not being able to enter the body. And this is a time where malnutrition can be an issue. And our job and our responsibility is perhaps to contact the registered dietitian for a more complete evaluation. And this is something that you would work closely with your provider to decide, when is the time to call another professional into the plan of care. Remembering that moderate to severe nutritional depletion is associated with longer stays in the hospital, and it can actually contribute to higher readmission rates and even can contribute to death. So this terminology, iatrogenic malnutrition, really it is an inadvertent cause of treatment or diagnostic procedure. So it's because of the things that we are introducing in the hospital, like tests and surgical procedures and interruptions in medication, we can actually be part of the cause of their decline in nutrition status. So please pay attention to nutrition, screening and reevaluating often, and also monitoring for diet orders, looking to see, NPO orders, how long this has been, and of course, any transition to solid foods, helping to get more of the specialists and experts involved. Really stressing now, again, the outcomes of malnutrition being poor wound healing, longer lengths of stay, decline in overall health. And going back to something we said earlier was the loss of appetite, depression, which also contributes to the loss of appetite, and any alterations in taste and smell perception from any type of disease process. But also as we get older, we lose some of our astute ability to taste and smell. So those patients are going to be at higher risk. There are three types of adult malnutrition classifications. The first one is called starvation-related malnutrition, and this is a chronic starvation, but is not related to inflammation. Then we have a chronic disease-related malnutrition, and this is associated with inflammation of mild to moderate degree, so chronic inflammation. And then the last one is acute disease or injury related malnutrition. And so, although we will have some inflammation, this is more on an acute basis, and it could be of severe degrees. So, let me give you some examples. An example of starvation related malnutrition, and this is probably something that popped into your head already, is anorexia nervosa. Chronic malnutrition is you think about a patient with cancer, and someone that has acute disease related malnutrition, perhaps it's someone that has experienced a burn. There are also cultural and ethnic considerations. Think about what food means to a person, and how we view our food can be connected largely to aspects of our cultural, ethnic, and religious makeup. And because of this, we may have cultural, ethnic, or religious food preferences. And if we do, our patients do as well. And so we are there to serve our patients from a variety of diverse backgrounds, especially here in the United States. and within the different hospital, or excuse me, healthcare settings like hospitals, nursing homes, skilled nursing facilities, and even out in the community. Even in a public health perspective, you may be going into a patient's home. And so when we're providing care to our patients, we have to be sensitive to these cultural needs and what the expectation is to not only the patients, but also the family members. Thinking about who makes up the meals, who buys the food, who, I don't know if they, create a meal plan. Um, think about what you know about the foods within your own cultural or ethnic or religious background, and what your attitude is towards food. Sometimes food has a symbolic relationship or religious connotations, and we have to consider all of those things before we can put a plan into place. Because consider putting a plan into place for a person that has no preference for the foods that you're putting on the plan. What are the chances that they can follow the plan or easily follow the plan? And it is impossible for any one person to know all the specific cultural food practices and all the diverse um, outlooks about food globally. So we have to ask the right questions and we need to go to the right resources. You can use a cultural nutrition assessment guide, and a guide specifically that is out in practice is by Andrews and Boyle, and it can help you to understand some of the information and provide you some questions to ask for a patient's health history depending on the patient's background. So some of the things that you can ask are like, what nutritional factors are influenced by your cultural background? What's the meaning of food and eating? Um, what do you usually eat? And what's the usual timing, sequencing of meals? So not only do we want to think about what they eat, but how often and when. Also, what does your patient understand as being a healthy food versus an unhealthy food? Other things to consider is that if they have any preferences and limitations of food, so if their choice is to be vegetarian or vegan versus the need to perhaps have a gluten-free diet because they have a disease process that warrants that. So trying to really understand and pinpoint what is important to the patient. So, providing nutritional care really starts when your patient is recognized as being at risk or nutritional risk. And then we start to um, think about what additional services and support may be needed or required by the patient so that we can help to either attain or maintain a positive nutritional status, especially throughout their stay in the hospital, but then moving on upon discharge. And the nutrition care process, or the NCP, by definition, is a systematic problem solving method that dietetic professionals use to really critically think and make decisions that will address nutrition related problems. And it will help to provide safe and effective quality nutrition care. So there are four parts that are interrelated and associated. So these steps, if it's possible for you to put them in place, this is what we need to do. We need to make sure that they get a nutrition assessment, diagnosis, intervention, monitoring, and evaluation. Now, it's not possible or necessary to complete a full nutrition assessment on every single patient that you're working with, but it is necessary, however, to have some type of system in place to be able to quickly identify if a person is at risk for nutritional problems. And this is supported by the Joint Commission, and nutrition screening is required within 48 hours of a hospital admission. And we need to be able to identify who's at risk and who are the people that need to be brought in to improve the nutritional status of this patient. And many times there'll be additional referrals that are going to be required for further in-depth assessment. So don't feel like you are the only person as the nurse at the bedside that is required to make these decisions. Who can initiate these nutrition screenings, however? It can be executed by nurses, registered dietitians, dietetic techs, dietary managers, physicians, and nurse practitioners, physician assistants, and other trained professionals that directly work with patients' health in terms of their diet and nutrition status. We're going to talk about the 4 steps of the nutrition care process model. And the first step is the nutrition assessment. And there are techniques that are outlined previously and very systematically. We've discussed how to obtain this information for assessment and reassessment. And we think about if a diagnosis already exists or if there's an existing nutrition problem. If so, then the problem is diagnosed using the PES statement in step 2, which is the problem, etiology, signs, and symptoms. The second step is the nutrition diagnosis. And before any type of intervention can be put in place, we have to understand what the problem is in the first place. The identification is accomplished with the nutrition diagnosis. And this is a standardized language that's been developed to make nutrition diagnoses clear for other nutrition professionals, but also the healthcare professionals that make up the interdisciplinary team. Once this nutrition problem is identified and your patient has a standardized diagnosis, and we're using these standardized diagnostic terms, the diagnosis can be made, or the PES statement. Again, that stands for the problem, the etiology of the problem, the signs and the symptoms that are associated with the problem. And typically, nutrition diagnoses will fall under one of the 3 categories. It's an issue with intake, it's a clinical issue, or a behavioral environmental issue. The third step is the intervention, and nutrition intervention begins once the diagnosis has been identified, and it really is generally aimed at the etiology of the problem. It's directed at reducing or eradicating the effects of the signs and symptoms. And these the nutrition interventions are intended to modify whatever the problem is, the nutrition-related problem is, to compromise the 2 interconnected components, which are planning and implementation. We prioritize nutrition diagnosis in the planning component by using an action phase. And the plan is communicated and carried out then, the data is collected, and the nutrition intervention is revised if necessary upon re-evaluation. There are 4 categories or domains of nutrition intervention that are identified. The first one is food or nutrient delivery, nutrition education, nutrition counseling, and then the coordination of care. And lastly, step 4 is the nutrition monitoring and evaluation. And at this point, the monitoring and evaluation in the NCP is really to measure the improvement that has been made by the patient. Are they meeting their nutritional care goals? The progress of the patient is examined by determining whether the nutrition intervention that was implemented is providing evidence of a improvement or an alteration of the patient's nutrition status. Nutrition monitoring and evaluation terms are then characterized into 4 different categories. The first step of a formal NCP is a comprehensive nutritional assessment conducted by the registered dietitian. They're collecting all the information from different sources, the chart, the information you gathered perhaps, and their own interview. And because no one parameter directly measures their nutritional status, it really has to be determined by what are all the problems and identifying the needs to improve. And so you can provide a nutritional assessment by taking on the ABCD method, which is getting anthropometric information, biochemical information, clinical information, and doing a dietary assessment. So within the anthropometric assessment, which is pretty simple and also non-invasive, we're just getting numbers. We're getting height and weight, head circumference, we're getting skin fold thickness, and the effectiveness of a single anthropometric measurement is very limited, and this is why we need more information. But getting a serial or series of measurements can be useful to understanding the body composition changes and growth over time. So watching the trend. And the standard techniques must be used to obtain valid and reliable measurements. And so whoever is collecting this data really needs to understand how to properly measure, what are the reference limits or cutoff points, and how these numbers are classified to see the risk categories. Other things that we can use have to do with the biochemical assessment. So think about routine blood and urine lab results that are recorded in a chart, thinking about how these tests are being interpreted, and knowing and understanding that no single test is going to evaluate short-term responses to nutritional therapy. Really, again, we're looking at the trend over time in addition to the anthropometric data. Also, we are looking at the clinical data and the results of dietary intake over a period of time in their hospital stay. Now, some tests may be inappropriate for certain patients. So think about a patient, for example, serum albumin. That might not be useful for the evaluation of a protein in patients that have liver failure, because when you are collecting albumin, those reference points assume that you have normal liver function. Also, lab tests that are conducted serially or multiple times a day or every day, this is going to give us more accurate information than just testing it one time. However, we don't always have the luxury of getting serial measurements. In long-term care facilities or acute care facilities, serial measurements they can be obtained, but they rarely are. Most of these patients are hospitalized long enough for these serial measurements to actually be obtained. And because of this, we do lack some of the information that is needed. Biochemical parameters can be used to evaluate visceral proteins, immune function, and this can all tell us about the nutrition status of our patients. Now, visceral proteins, you're probably wondering, are proteins found in internal organs and blood rather than the muscle itself. And visceral protein status is estimated by serum albumin and prealbumin. And this interpretation of these albumin values, we have to again be cautious because inflammation, infection, hydration, and other illness really do affect these values. And lower values don't necessarily mean that the patient has a poor dietary intake of protein. So we have to look at the holistic picture. BMI or body mass index, this is the ratio of height to weight, and it's been associated with overall mortality and nutrition risk. So many studies have determined that BMI is a good way to assess risk. However, there are also studies that have shown the opposite to be true. But currently, it is a accepted way to assess for nutrition status. BMI doesn't determine your body composition, meaning it doesn't determine lean body mass or adipose tissue, but it is a gauge of overall total body fat. And some genetic markers are correlated with high body fat percentages, with death from cardiovascular diseases. And so this is coming out of a study from Schnur et al. And although we have BMI measurements being useful, they also have some limitations. Um, BMI has not been validated in acutely ill patients and sometimes can be underestimated in terms of how we determine body fat in the elderly and those who have recently lost muscle mass. BMI can also overestimate body fat in those patients that have a more muscular build. Cardiorespiratory fitness, or CRF, is a potential modifier because the risk of all-cause mortality, it's lowest in the overweight category. Additionally, we can determine BMI by dividing the weight of your patient in kilograms by the height in squared meters. And you can follow these steps. So divide the weight in pounds. So if you're 100 pounds, you're going to divide that by 2.2, and this is going to convert into the kilograms. Once you get your kilograms, you're going to multiply height in inches by 2.54, and then divide the result of that by 100 to convert height to meters. Then you multiply height in meters by itself because you're squaring it. Divide the weight in kilograms by the square of the height in meters, and the result is going to be your BMI. Now, luckily, you don't have to memorize this whole process, although it is good to know, but there are many BMI calculators that will help you do this, and oftentimes it will be calculated within the electronic medical record. The desired BMI range for a healthy adult is 18.5 to 24.9 kilograms per meter squared, and this reflects a healthy weight-height ratio. Now, lower risk for health problems are associated with people that fall within these BMI numbers, and this is what makes it a desirable level. A patient with a BMI less than 18.5 kilograms per meter squared, this is a classification of being underweight, and it is also associated with some risk factors such as respiratory disease, TB, digestive diseases, and even some cancers. In terms of the clinical assessment, we're getting this information or the data from several sources. We're getting it from the medical history, coming straight from the patient, or sometimes their significant other or family members. You are also going to collect social history and conduct a physical examination. Other factors to consider are environmental, social, family history, and past and present medical factors, which also can alter nutritional status. Where do we find this information? Upon interview, as we discussed, but also can be in previous medical records within the facility that you're working, but you might need to get some outside records from other facilities that have treated the patient or other healthcare clinics that have seen the patient. And there are many physical signs and symptoms that are associated with malnutrition, and we are looking at this as being an integral part of assessing the overall health status. Now, features that are associated with nutrition deficiency can be identified through getting the histories and also the clinical categories. Acquiring the historical data includes asking about not only their overall health and medical history, but also if there's incidences of poverty, avoidance of specific food groups like dairy, meat, fruits, or vegetables, and this can be by choice or it could be what has been previously recommended. Any weight changes, the use of nicotine, drug, or alcohol, family medical history, and dietary supplement use. Other clinical factors include any recent surgeries, wounds, any recent blood loss. Have there been changes in hair and skin? And this can also give us an overall idea of their health status. And finally, we can organize this information according to symptoms of their eyes, face, skin, muscles, tongue, and the central nervous system. think about the things that you already know about nutrition status and what you learned in health assessment. For example, we know that with spoon-shaped meals, this can be a sign of iron deficiency anemia. There are several methods for collecting information about actual and habitual dietary intake, and this can come from a historical and retrospective dietary recall method or food record. And so you can ask them to talk about what they've eaten in the past of things that they, information that they may have collected previous. So having some type of diet or food diary, or perhaps um, you can do some prospective work in asking them to keep some food records so that you can see future trends and improvements or worsening of habits. Now, each method has a pro and con, so it's important to choose a method that's suitable for what the um, situation is and what type of information you're trying to collect. The intake records that can help are also important. They provide information about calories or kilocalories, to be more specific, protein, carbs, fats, vitamins, minerals, and fluids. And it can be calculated manually with a food composition table, and it can also be analyzed by certain computer softwares and applications. There are many programs and applications out there that can help analyze your dietary intake. Many of us have them already uploaded on our phones. So it's the same idea. The one that you are probably familiar with and we use quite often in healthcare is a 24-hour diet recall. And the patient is asked by the interviewer, in this case the nurse, to report all the foods and beverages that you've eaten during the past 24 hours. And we tried to get detailed information about the types of foods, beverages, how were they cooked, if they understand brand names, what condiments and supplements were used. The portion size is also important. And you want to see if this is obviously something that is a good idea of what they're eating day to day, or is this something that doesn't usually happen, right? They don't usually eat this well, or they don't usually eat this bad. So you have to collect that information also. Now, the advantage of this method is that it's quick. It usually only takes about 15 to 20 minutes if you're getting a really detailed 24-hour recall. And because it's retrospective, the patient is not modifying what they actually ate, right? So when you do something prospective, then this is something that they are being more proactive in collecting that information. And so some of that may change, which is actually pretty good. So if you're using it to help them change their habits and dietary intake, then getting a prospective evaluation is the method that I would choose. There's some drawbacks though to the 24-hour diet recall. It relies on memory, motivation, and also awareness. And many times people don't really remember or can give a detailed account of what they ate, even if it was in the last 24 hours. Food records sometimes can help provide a more realistic picture of the patient's usual intake because um, they are collecting, over a period of days, and usually it's over like at least 24 hours, but up to 1 week or 7 days. You also have to help train the patient if this is something you want them to collect on how they are measuring this information, the cooking methods, ingredients, all the descriptions of how the food was prepared should also be recorded accurately and completely. So again, the 7-day food record is considered the optimal amount of time for gathering this type of information, but it is tedious. So if your patient is unwilling to do a full 7 weeks, maybe a 3-day record, at least 2 weekdays and 1 weekend day. This is most common. Getting a complete calorie count is important in acute and long-term care settings. One of the most important forms of food records is actually the calorie count. All nutrients can be assessed, but energy and protein intakes are what really needs to be quantified mostly. Information gathered is used to determine the adequacy of the patient's daily oral intake, and we need to document this and figure out what we need to do to support their nutrition. And think about any nutrition intervention used to minimize patient morbidity, mortality, and complications. That's what we're talking about here. Our own nursing observations are essential for the early identification of malnutrition and also the prevention of weight loss during the hospital stay. Staff, including nurses, are responsible for recording the calorie intake. It has to be accurate in our recordings, and it's important to record things that are not provided by the hospital, perhaps food that was brought in from family members or visitors. You also want to think about the percentage that was eaten. Did they eat 50% of their baked chicken on their plate? Did they eat 100% of the bread on their plate? 25% of the green beans? So you can use subjective terms such as 2 bites or 8 well or 3 swallows, but it doesn't give us the information that we really are looking for. It gives us an anecdotal picture of the patient's nutrition status, but we're really looking for numbers that can quantify, because we need objective information to calculate protein and kilocalorie intake. The nutrition care process involves assessing the nutrition status and estimating nutritional needs, but also determining whether there's a problem that we need to treat. And what are we going to do with that problem? How do we plan a nutrition intervention? And if we do all of these things appropriately and provide early intervention as a form of treatment, we can help to prevent malnutrition, especially in those patients that are at higher risk. So, things to consider for nutrition risk are their age, lab results, weight, body systems, and how we are feeding or feeding modalities. So in terms of age, there are some age-related high-risk patients, especially those that are 75 years or older, and children that are younger than 5 years. We're also looking at the severity of their disorder. There's conditions affecting our various body systems that can pose either a moderate or higher nutrition risk. Moderate nutrition risk can be experienced, for example, when a patient is undergoing chemotherapy because of its effects on our dietary intake. High risk is incurred when we have patients with eating disorders, or perhaps we have a pregnant woman with diabetes. In terms of the feeding modalities or modes, the risk is high when we have modified diets that have the potential to cause a nutrition deficiency. So if you have a patient, they could be at high risk if they're receiving some type of parenteral feeding or tube feeding, and they are only getting parenteral feeding and nothing by mouth or NPO. If they are only consuming clear liquids for more than 3 days, they're also going to be at risk. Now, one of the key aspects of our assessment, our nutrition assessment to be more specific, and patient care, it really includes this ongoing review of any potential or actual food drug and drug nutrient interactions. And all drugs have a physiologic effect on the body, and some of which are unintended, the side effects. And this could be a risk of medication use. The amount and the rate of how our drugs are absorbed in the body can be affected by the composition of how we're eating, the timing of food intake. Conversely, though, food intake, the absorption and metabolism of our food, can also be altered by our medication. So, drug nutrition interactions can reduce the efficacy of the drug. It can interfere with the disease control that that drug is trying to provide, and it can further foster nutritional deficiencies. And there are key interventions that involve a change in foods or nutrients that can be determined by patient education, counseling, and coordination with the registered dietitian and the healthcare team. Furthermore, the Joint Commission really strongly recommends evaluating drug and diet combinations, and this can be done by the registered dietitian, but ultimately, as a nurse, you should be considering this as part of your care with your patients. Additionally, um, medications and food and nutrients, we're also thinking about the use of alcohol and other types of illicit street drugs that could affect our patient's nutrition status and nutrient requirements. So how do we determine if a patient is at risk for drug nutrient reactions? We really have to think of who this individual is. First, let's talk about their age. We know that older adults are more at risk for drug nutrient reactions. They have a greater variety of medications usually. They have reduced physiologic functioning because of their older age. And this is going to overall affect their drug absorption and the efficacy of these drugs. Additionally, young children can also be affected by drug nutrient interactions, depending on what vitamins and minerals they're using, dietary supplements, and over the counter medications, perhaps that are intended for adults. Really, if a child is taking it, it can result in a drug nutrient reaction too, because the substances are metabolized differently. In terms of physiologic status, think about how each individual metabolizes and absorbs, excretes nutrients and medications, all differently. But there are some disorders that will impair the ability to absorb, metabolize, and excrete nutrients and medications, such as disorders of the GI tract. Or if you have a patient that has a reduction in hepatic and renal functioning, this is also going to increase that risk for drug nutrient reactions and how the drugs are absorbed and metabolized and excreted. What if you had a patient that undergone or has undergone some type of surgery? Maybe they are post-op trauma patient. This can sometimes trigger an atypical physiologic response to drug nutrient interactions as well. And drug doses can vary according to a person's weight and metabolic function. And this is an aspect of age-related physiologic status. So we might need to change the drug dosing on a patient with a altered renal or hepatic function. We also know that the use of medications during pregnancy requires much caution and sometimes can be very limiting, but we're really trying to deter the multiple effects that it can have on the fetus and even the nutritional status of the mother. With polypharmacy, which is a term that we use to say that a patient is on multiple drugs, there are certain diseases and illnesses that tend to require this combination. You think of a patient that has multiple comorbidities of diabetes and hypertension. They may be on multiple medications for the relief of the symptoms, but they also might be on some over-counter drugs as well. This can result in drug nutrient reactions that are related to the disease itself or can be a reaction to the medication. Let me give you another example. If you have a patient that is experiencing intestinal bleeding that causes iron deficiency anemia because of the loss of blood, they now have a nutritional risk factor, right? So they have iron deficiency anemia. But perhaps they have this intestinal bleeding because they are a patient with arthritis and they might have been taking a lot of NSAIDs that are promoting this intestinal bleeding. This is a common side effect of long-term use of non-steroidal anti-inflammatory drugs, and this could be either prescribed or over the counter. Influence of a typical dietary intake, the basis of the person's nutritional status really depends on the foods that are regularly consumed, and therefore you really want to understand what is the patient's norm and what are they normally eating, but also what are the drugs or medications that they are normally taking. So not only are we trying to understand what they have been prescribed, but what are they complying with. The drugs and the effects of these drugs on food and nutrients really has to do with the absorption that occurs within the GI mucosa. Predominantly, this is happening in the intestines.
And before any drug can be absorbed, it has to be first metabolized, and so it dissolves in the gastric juices in your stomach. And how fast these drugs leave the stomach depends on your gastric emptying time, which also affects the rate of absorption. And so this rate can either increase or decrease depending on how much food you have in the GI tract also. And so in a fasting state, the medication leaves the stomach really quickly because there's nothing else for it to be absorbed with or broken down with. And therefore, it's going to be absorbed from the small intestines quicker. But some drugs, if they're absorbed too quickly, then this can also be an issue because time is needed for their disintegration into absorbable particles. And so if they're leaving this process from the small intestine too quickly, it may not be effective. So for these drugs, it's better to take the medication in a fed state or with a full stomach. And your stomach should contain food so that it empties more slowly and that the drug itself can be broken down. And um, it requires a slower emptying time. But then you have drugs that require a quicker emptying time, and this is when you're going to tell your patient to take the drug on an empty stomach. Now, drugs can alter food intake, nutrient absorption, metabolism, and excretion, and these drugs include not only the prescription medications, but over-the-counter drug medications as well, and even alcohol. Now, drugs that are used to lower cholesterol levels, for instance, they bind with fat-soluble vitamins and bile salts, and so as a result, both the bile salts and vitamins are going to be excreted. So would you want to take them at the same time? Now, some drugs can decrease the number of digestive enzymes that are available, which will then decrease the absorption of your nutrients. So this is something to consider as well. There are some foods and nutrients that also affect our drugs. So think about some MAO inhibitors or monoamine oxidase inhibitors, which are provided to patients to treat depression. These drugs inhibit the enzyme monoamine oxidase. This is why it's called a monoamine oxidase inhibitor. This enzyme, as it's inhibiting, the function of which it is to inactivate tyramine found in some foods. But without monoamine oxidase, the level of tyramine will continue to increase and release norepinephrine. When you have elevations of norepinephrine, it can cause headache, pallor, palpitations, and life-threatening severe hypertension. And these patients that take these MAO inhibitors should avoid foods that have tyramine or other drugs that contain tyramine. So what are these drugs? Chianti wine, aged cheeses, and fermented foods. There's a longer list in the textbook, and you can also look in your facility's diet manual, depending on what hospital or care facility you're working in. And you can always discuss this with the dietitian and the pharmacist. Now, medications have to be absorbed to have a therapeutic effect, and food intake and the composition of food can affect absorption, which we've established. The timing of drug administration is also important, and if the absorption is increased by the presence of food or decreased by the presence of food, we need to understand that. If the drug's absorption is depressed by the presence of food in the stomach, then the optimal time is to be taken at least an hour before or 2 hours after you're eating, or even after tube feeding. As a general guideline, drugs should be given at least 1 hour before or 2 hours after a meal unless the medication causes some type of GI distress when you're taking it on an empty stomach. And in this case, timing should enhance the drug absorption and decrease the hindrance of nutrient absorption. Now, with tube feedings, there are other issues that we need to think about. Drug-nutrient interactions can compromise pharmacologic and nutritional objectives of safety, efficacy, and quality of care. And this is why we need to think about how these interactions can affect not only the patient overall, but also Is it cost effective in their treatment if you are providing them drugs, not giving it during the right time, and therefore it's not really working or being absorbed appropriately? Before administering any oral drug through a gastric or nasogastric feeding tube, you have to ask yourself some questions. First, is the tube placed correctly? Is this medication something that you can be crushed in the first place and delivered through a feeding tube? What are the interactions going to be between the medication and the feeding solution? Um, think about, will it alter the medication's availability? Will it clog the tube? You're also thinking about the osmolality and the pH in the feeding system. Is it causing nausea, vomiting, cramping, or diarrhea? And again, referring back to the pharmacist, they have valuable expertise. They can help to optimize prescriptions. And so you want to use your connections with the pharmacist as a resource. The number of potential drug feeding interactions, especially in tube feedings, like with feeding formulas, it is pretty endless, and there's new medications all the time and new feeding formulas, and you cannot be expected to know everything. So please consult with an expert, here being the pharmacist or pharmacy services, so that they can help you to determine if there's any incompatibilities or recommendations that alternatively need to be thought about with tube feeding. Additionally, in terms of foods and nutrients, think about herbs that are on our foods. They can significantly affect the bioavailability of the food, the nutrient, and even the drugs. And we have seen herb and drug interactions as well. Now, of concern are the effects of commonly used herbs, especially on the body that is undergoing a surgical procedure. For instance, ginkgo, garlic, ginger, ginseng. These can all affect clotting of the blood. Other herbs such as valerian, kava can also cause liver damage, but also St. John's wort. These can all prolong the effects of narcotics and anesthetic drugs. So many times upon intake for surgery, we are asking the patients to stop taking these supplements or herbs um, couple weeks before surgery, and we're also asking them if they took any, the day of surgery, which would not be a good thing. You might have to cancel the surgical procedure. You want to ask detailed questions about the patient's supplement intake. So you're asking them point blank, do you use any dietary supplements, and give them some time to think about that for a second. And if they don't say anything, you might prompt them and say, are there any vitamins or minerals, um, supplements, extracts, concentrates that you're taking? Finally, if they say yes, you want to know the dosage and what other directions they follow in taking these supplements and herbs. Are they taking it with meals, taking it at bedtime, once a day, once a week, etc.? And also ask why or what the purpose of these dietary supplements are. You don't want to say things like, what is that supposed to do for you? Because it implies that you are kind of skeptical about what they are taking. They might feel a little bit embarrassed, ashamed, or upset that you're asking. And so that really does discourage honest um, information or, an honest reporting of their supplement use. So ask in a kinder way and more comprehensive way, what's the purpose of this dietary supplement for you?